Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner, Dr. Raafae Hussain.
Hello, hello.
And we are going to jump right into discussing diabetic foot ulcers and some of the latest, I think, thoughts on how dangerous they are, for one, and then also some of the ways that we can get these lesions closed and try to prevent amputation. So without further delay, Dr. Hussain, what do you got for us here?
Yeah, so diabetic foot ulcers, a very, very common problem that we see in the world of podiatry. Probably the most common reason for foot ulcers in general, but I just wanted to do a broad overview of what other type of foot ulcers there are, or lower extremity ulcers that are common to our practice. So if you're looking at the slides, we have venous stasis ulcers, very common due to venous regurg or venous insufficiency. What ends up happening is the blood flow coming down is great, or to an extent, and the blood flow coming back up isn't the greatest. So you end up getting a blowout of the skin. The skin ends up getting irregular pattern of ulcers. There's very sensitive. I mean, these are pretty
sensate patients, yeah. So these can be very painful. So one of the major instigating factors is a problem with excuse me, problem with the valves, right? Problem with the venous valve system, and so those valves get destroyed often because of a clot. When the clots get resorbed, they unfortunately destroy the valve, and you get chronic edema or chronic swelling in the gaiter area, which is that area around the ankle. And the yellow appearance is slough. That is a sort of a byproduct of the wound healing process that can get in the way. And these wounds are usually in people who have sensation, so they can be really painful.
Yeah, ultra tender.
Yes. And they're really tough to heal in some cases because treating the edema can be difficult. Now, that's again where we work closely with our interventional radiologists, interventional cardiologists, and vascular surgeons who do venous work to try to address the underlying perforators or whatever is causing this lack of return. And they can usually knock those out, improve the situation from a vascular standpoint, and then the overlying wound can close. So I think one of the things to remember about these also is when you see a wound like that in that far left picture, if they've had a wound there for years and years and years, man, you got to biopsy that thing.
Yeah, it could be any type of cancerous lesion, squamous cell. I mean,
those can get missed, and it could be only a portion of the wound, so you may need to biopsy several areas of the wound. But it's not out of the question that a wound like that can end up being, some sort of cancerous lesion that has just been missed. So that's definitely something to keep in mind. Arterial ulcers.
Yes, so that's your poor blood flow ulcers. Your blood coming down isn't the greatest. Imagine like you're throwing a rubber band around your finger. The blood gets cut off. Your finger becomes ultra sensitive. Imagine that to exponential extent. Mm-hmm. You got no blood flow coming to an area, and that's when you get the gangrenes. That black spot is called an eschar, but it's a superficial gangrenous wound. I mean,
dry gangrene. Mm-hmm.
Yeah.
And these are oftentimes smokers, people who've smoked for decades. We know that smoking affects the lungs, but it has a tremendous effect, a negative impact on our peripheral vascular system, our arterial intima. The intima gets irritated by the nicotine is the thought, and you start getting plaque buildup. You start getting narrowing of these blood vessels. You get atherosclerosis where the vessels are getting hard, and all of that can lead to blockages that can cause tissue death, which is what happened in this case. And so the patient may have no lesions, and they may have some minor trauma, like they wore a boot that they don't usually wear, and that pressure point then breaks down, and the patient's like, oh, the boot did it. Well, yeah, the boot may have been the thing that pushed it over the hump, but you had the background vascular disease for years because you were a 50-year smoker of 3 packs a day. So, we have to have that discussion with folks, and they may have quit, 10, 15 years ago, but they're still paying the price And so there are blockages that can be opened up, and that's where, again, we work really closely with our interventional radiologists and interventional cardiologists and vascular surgeons to open these blood vessels up, try to save the limb, if it's possible. And oftentimes they can do that endovascularly, where they're going through small incisions in the groin, and then doing balloon angioplasty or putting in a stent, which is like a cage that opens up and holds the blood vessel open. But again, yeah, this is where pressure points are really a problem. So we work closely in our diabetic patients specifically who have vascular disease on top of their diabetes, and trying to prevent these pressure points so we can, prevent new lesions. But these are tough. These are some of the hardest things to treat, because you're at the mercy of the blood flow. You're at the mercy of the plumbing.
Yeah. The next type we have are neuropathic diabetic ulcers. These are caused by diabetic patients who have lack of sensation. I don't know if they should be called neuropathic diabetic or just plainly neuropathic ulcers. The main problem is the neuropathy. You're not feeling the sensation in the bottom of your feet. You're walking through the sores and blisters that form, and ends up causing a small ulcer, bottom of your foot, your heel, your toe, wherever it may be. It ends up being a pressure point where the constant trauma is fighting to heal, and your body isn't allowing to heal because you're constantly putting more and more trauma on it, aside from poor blood flow, uncontrolled diabetes, and other problems that are associated with it.
And there's almost always some sort of deformity involved. Like in this patient, in that third picture there with the plantar wound underneath the second metatarsal head, that patient's got hammer toes, and that toe is contracted. It's causing a retrograde force, meaning a backing force from the toe back to the metatarsal head, pushing that metatarsal through the bottom of the foot, essentially. And if it was in someone who had sensation, that pressure point would probably be uncomfortable, and they would address it either with changes in shoe gear, or come see the podiatrist and get it padded, or address the callus that's building up there. But in this case, this is probably a callus that got thicker and thicker and thicker until finally, you end up with a wound underneath it. So, almost always there's some deformity involved with these pressure point ulcers that we see in the forefoot, and even in other parts of the dorsal aspect, or the top of the toes. It's another place where shoes will wear on it, and it's almost always because of the hammer toe. So we see these a lot in neuropathic patients. Obviously, this is one of the most common wounds that we see every day in our wound center, and in the office, and it's limb and life threatening. It is as dangerous as colon cancer, and that's a shock to some people when they hear that. I mean, I'm sure you've said that to patients where you're like, hey, look, you need to treat this with the utmost urgency, because this is a wound that is threatening your limb every day it's open. Yeah.
Very, very easy to treat if you address it properly. Mm-hmm. A lot of patients are like, it doesn't bother me. It's not painful, but that's exactly the cause of the problem.
Right. Yeah. It's sort of a double-edged sword. It makes it easier for us to debride them because they're not having pain, but they wouldn't have the wound in the first place if they had normal sensation. So when it's your first wound, hopefully that's an eye opener. It gets frustrating as the treating physician if your patient continues to get them over and over for completely preventable reasons. And that's what we try to counsel folks on. Like, hey, look, we need to get you into some diabetic shoes. We need to try to prevent some of the forces that were causing this. And sometimes we have to do surgery to address the deformity that's causing it. And that's not, I think, too aggressive at all. I think it's whatever you need to do to be able to prevent the wounds, because the wounds are so incredibly dangerous.
Yeah, and once you have a wound, you're more predisposed to having them over and over again. And there's a reason you're getting the pressure sore to begin with. It's not that, I wore poor shoes that one day and now it's going to get better from wearing proper shoes. No, we need to address the problem. And like for this example, like Dr. D said, it's the second metatarsal that's plantar flexed, meaning it's closer to the ground as compared to the other metatarsals, and we need to bring that back up and make it an even surface, even plane for them to walk on.
Yeah, distributing weight better. And sometimes you can do that. Oftentimes we can get these closed with offloading. We can get them onto a knee scooter. We can do some things to offload and then get the wound closed, and then get them into diabetic shoes. And if that works, then they won't get the wound back in the same place. If that doesn't work, then you're really forced to at least entertain the idea of surgical correction of the deformity. And then that's a surgical offloading that can be extremely effective and is more a long-term solution.
Yeah. The last one is pressure ulcers. they kind of work hand in hand with the diabetic and arterial ulcer situation where there's an excess amount of pressure. Most commonly in pressure-specific ulcers, they're bed-bound or they're wheelchair-bound, or they have
just had surgery. Maybe they just had a hip replacement and
Yeah.
no one's paying attention.
So literally pressure, you're putting excess amount of pressure, the skin breaks down, and you end up getting a wound there. If you imagine that a healthy young adult is sleeping, they roll over multiple times at night because they're putting a lot of pressure in one place. A patient who's bedbound and cannot move, they don't move, and the reason that you move is because of that pressure, the uncomfortableness. I mean,
you're causing ischemia, so you're causing local blood flow problems that end up causing pain in someone who has normal sensation.
Yeah, and that's why it's very important for hospital staff or nursing home staff to, when they have patients who are bedbound or wheelchair bound, that they rotate them, they move them, they put them on an air mattress, they have them in offloading booties.
Multi-PODus boots are
Yeah.
effective when it's a recurrent problem. Yeah, so that's a boot that literally has a space between the back of the boot and the heel, so the heel is completely floated. So yeah, I've had I've had discussions with family members who are about to have hip surgery. Like my dad's supposed to have hip surgery soon, and I'm going to make sure that that the family understands. Hey, look, he's going to be at high risk for pressure ulcers because of his age, because of the immobility, the bedbound status during the initial post-op period. He's going to be at high risk for these, and they need to keep an eye out. They need to float his heels and use pillows behind his calf. So, even if you're listening to this podcast and you don't have one of these, but you have family members who are getting older and are going to be having, knee surgery, hip surgery, this is something you can absolutely have an impact on by making sure that their pressure points are being addressed so that they don't end up with one of these. Because it's interesting now, the hospitals, Medicare penalizes hospitals for allowing these to happen now.
Yeah.
So there's a certain percentage of that hospital visit if they get a iatrogenic, or a hospital. There's a term for it.
It's iatrogenic.
Yeah, essentially an iatrogenic wound. They're being bedbound in the hospital. These are preventable. If they don't do the things they need to do to prevent them, then the hospital can get dinged on the financial side.
Yeah. So that's just a general overview of the types of ulcers that we see. Today we're going to be talking about diabetic foot ulcers specifically, and then we'll go into these other topics eventually down the line. So diabetic foot ulcers, very, very common. They estimate that 15% of all people with a diabetic foot ulcer will experience an amputation at some time in their life. 15%. That's, if you know any diabetics, that's like 1 in 8, right? Rough estimate. 1 in some, whatever, close to that number. 1 in 9. That is an extremely high number. Imagine a school bus full of diabetics. That's extremely, extremely high risk for anyone to get any type of amputation. This isn't just ulcers. This is amputations.
Right. And with 30 plus million people, I mean, I think that number is kind of low now. I think if you look at the latest stats, it's quite a bit higher than that. But yeah, I mean, if you're thinking 15% of those folks, with diabetes are going to end up. This is 15% of people with a diabetic.
With a diabetic foot ulcer.
Okay, so yeah, diabetics with ulcers, and then the patients who have a major amputation, that mortality rate is really scary. So it depends on who you read, but the 5-year survival rate may be only 45%, 40%.
Yeah, the newest numbers are actually at 3-year 50% mark. The more updated numbers.
Yeah, I don't doubt that.
Yeah, and I mean, if you're thinking, oh no, my family, we have diabetics and no one's ever had an amputation. I mean, just count the numbers. Maybe further down the line, if 1 in 8 people are getting amputations, and 7 diabetics, you're the lucky few that haven't.
And the percentage of U.S. adults that are affected by diabetes just keeps growing. This is 12.2%.
Oh, I think it's higher than that now.
In Texas, the Texas Diabetes Council was estimating by 2020 we'd have 4 million diabetics, and I don't know if that came out to be true, but we're probably pretty close. And they were expecting by 2040 that we'd have 8 million just in Texas, and that would be, on the growth estimates of the population in Texas, that would be a quarter of the entire state. So if that comes true, a quarter of the state being diabetic by 2040, there aren't going to be enough of us to treat these folks for all the complications that they're going to be suffering from, including, diabetic foot ulcers, which are, again, as dangerous as colon cancer and threaten the limb every day they're open. Yeah, 25% of diabetics will develop a foot ulcer in their lifetime, and that stat seems to be pretty accurate long term. And peripheral neuropathy and peripheral vascular disease are the two drivers of that for sure.
Yeah, and they work hand in hand. You can see that there's a 5-fold increase with any type of foot ulcers with diabetes when you have any type of vascular problem.
Right, and it's something that can be very subtle and scary, because with the sensory loss, you may not be fully aware of how much arterial flow you're missing, and until you have an injury that doesn't heal. So that's really scary. When people would typically have calf pain, they'd have claudication pain. So when you have severe arterial disease and you walk a couple of blocks and your calf starts to burn, that's called claudication, and that's ischemic pain, or lack of blood flow to the calf muscle pain. We can measure that on the number of blocks. Let's say you could walk 5 blocks last year, but now you can only walk 2 blocks, and then your calves are burning. You got to sit down, you got to rub them. You're heading down the wrong path. That's a patient who needs intervention pretty quickly, because the blood flow is being so diminished that they're getting ischemic pain with just a few steps. So that, or even patients who tell you that, hey, I can't stand having my feet elevated. I can't sleep at night unless my feet are hanging off the bed.
Off the bed, yeah.
Yeah, that night pain that is positional is telling you that you've got severe arterial insufficiency.
Yeah.
What we would call critical limb ischemia, and that's something that needs to be addressed. And again, we really work closely with our interventional guys to identify these patients and then address it as quickly as possible, because you can lose tissue pretty quickly.
Yeah, I mean, back to the amputation rate. 5-year post-amputation mortality rate is 50%. That means anyone who has an amputation within 5 years.
Well, that's major amputation.
Major limb amputation.
So, that would be like a below knee amputation or above knee amputation.
Yeah, luckily not toes.
No, yes, thankfully. But you lose a great toe, you're about 50% more likely to end up with another amputation within 2 years.
Yeah.
So that that's a significant problem. The loss of the big toe, or the hallux as we call it, throws off the mechanics, and so you've got to be able to address that with shoe gear and sort of a prosthetic that you can use inside the shoe to protect the rest of the toes. Otherwise, they end up with other ulcers that lead to amputation. So if your feet are at risk, if you have neuropathy, if you've got deformities, if you have a history of foot ulcers, you really need to be in our care, one way or the other, routinely, so that we can keep you out of trouble.
Yeah, it's a team effort. It's your primary care, your endocrinologist, your diabetic specialist, your vascular doctor, and then your podiatrist. And
then infectious disease, if you have osteomyelitis or bone infection involved, it really is it takes a team effort for sure.
Yeah, I highlighted this stat at the bottom that foot ulcers precede 80% of non-traumatic lower extremity amputations. Only 80%. That means there's 20%. There's 1 in 5 out there who have a lower extremity amputation who didn't have a foot ulcer. And that's, from they stepped on a nail, they got some type of infection, they had, some type of trauma that broke the skin, got to the bone, and they had an amputation. But the good part about that is 80%. 80% are things that we see in clinic that we can help prevent. Any type of doctor, that could help prevent, not just podiatrists specifically. Your primary, your endocrinologist, your vascular doctor, your whoever's taking care of you. You tell them, look, I got a foot ulcer. You need to see a specialist. You need to see someone who can take care of wounds.
I think that's one of the wound care is interesting in the United States and probably elsewhere in the world too. Is just to get off on a tangent for a second. It's one of those subspecialties that many specialties are involved in now. So we have podiatric surgeons doing wound care, some in their offices, some in wound care centers. But in a lot of wound care centers, you have other specialists that have sort of retired into doing wound care. General surgeons, sometimes OB-GYN, endocrinology, general surgery. And not all of them have a broad spectrum background in wound healing and hyperbaric medicine. Some of them get hyperbaric medicine trained and wound care trained, but it wasn't necessarily part of their entire residency training, and it wasn't something they've really studied for decades until they retired. And I think it's good and bad because you get this perspective of all these different specialties, which I think can be really helpful, but not all of them are surgical specialties. Not all of them debride well. And if you're not going to spend the time to learn how to do a good debridement, and you're not going to spend the time to keep up and go to SAWC and go to the conferences, wound care conferences, and really get board certified in wound management. I think getting board certified in wound management is extremely important. One of the folks I'd like to interview is the president of the American Board of Wound Management.
Yeah,
I'd like to get their perspective on why that credential is important. I think it's extremely important. It forces you to stay up with the medicine, stay up with the technology, and make sure that you're treating patients to the highest degree possible, to the state of the art. Because if you're falling below that, I think you're putting patients' limbs at risk. And we can clearly see that when the limb is lost, it's a death sentence for these folks. So, I'll get off my soapbox about wound care.
No, it's true. I have a patient. I mean, I'm not going to drop names, but I have a patient right now, and their wound care doctor specialist is doing all silver dressings. Everything is silver on this patient, and it's been from day one.
Okay. So getting back to the topic here, I think this is a really nice overview of what's happening in diabetes. So yeah, Dr. Hussain, let's go through this. So
what happens with diabetes? It's not just that, your diabetes causes high sugars and, your sugars can get out of whack. But as far as diabetic foot ulcers are concerned, you get the sensory neuropathy. You end up getting damage to the nerves themselves. The nerves come down, they have tiny, thin filaments, as thin as hairs, some of them. They have vascular wrapping the nerves and the nerve sheets, the small arteries. And what ends up happening is glucose breaks down from fructose to sucrose to blah, 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 and all the way down to sorbitol. The sorbitol ends up wrapping or going in and to the level of the Schwann cells, which are wrapping the nerves, which are like your nerve conduit. And ends up injuring those nerves. You end up losing sensation. That's why when you first start getting neuropathy, the patients are commonly complaining of burning, tingling, numbness, paresthesias. That's like the sensation of having ants on your skin.
And one of the reasons that's a real issue that we've seen over the years is the neural edema. So when that sorbitol involves the peripheral nerve, it can pull water into the nerve as well, and that's causing these nerves to be sometimes 2 and 3 times the normal size. And we proved that. We wrote a paper in 2005 that was published in JATMA about the Journal of American Podiatric Medical Association, where we looked at cross-sectional area of the tibial nerve in diabetics, in non-diabetics, and in diabetics with neuropathy. And when you compared those 3 groups, you could clearly see that the diabetic patients who didn't have pain and neuropathy complaints, their tibial nerves were about the same size as the non-diabetics. But in those diabetics who end up with severe painful peripheral neuropathy and numbness, their nerves were 2 to 3 times the normal size. And so, we've extrapolated from that that's part of the mechanical problem that we can address surgically. And it's why diabetic patients get carpal tunnel. One of the reasons why diabetic patients get carpal tunnel, about 30% more likely than non-diabetics. Their tissues around the nerve get glycosylated and stiff, and then the nerve gets swollen. And that combination is a classic entrapment.
Yeah, well, so when Dr. D says glycosylated, that's pretty much, imagine your soft tissue is less elastic. Mm-hmm. It cross-links to an extent where it doesn't give anymore. It's like a rubber band who's gone stiff. And that in itself can cause impingement on the nerve. And that's when we were talking about going in and releasing those nerves.
Mm-hmm. And the motor neuropathy is interesting because when you've got basically a denervated muscle, and we have 4 layers of muscle in the arch of the foot, and when those muscles get denervated, where the nerve function to the muscle is now diminished to the extent that there's really no function there, those muscles will wither and atrophy. And when you look at them in the OR, they can be translucent. They don't look like the beefy red muscle tissue that you would expect. And that's where you get these foot deformities, these horrible claw toes. you can get the bunions can become a problem, and then even something as severe as Charcot can be an issue. And we'll talk all about Charcot neuroarthropathy. Probably have to do a whole episode just on that, because
that'd be a fun one.
That's a big one, yeah.
And the last thing that happens is the autonomic neuropathy. So those are the nerve fibers that are getting all the way to your skin and your sweat glands. So that's why when you have a diabetic, they have that diabetic dermopathy. Your skin doesn't look as healthy. If you compare a diabetic's skin from their forearm to their tibia, their shin, you can see a blatant difference.
And that leads to the lack of flexibility of the skin can lead to how quickly an ulcer can form. You've got this stiff, poorly vascularized tissue, and it can tear, it can break, it can develop calluses that then have ulcers underneath them. And that, you can see some of that change when you do a decompression of these nerves. You can see their skin quality improve. Yeah. And that's something that's a little bit hard to measure still. They have devices that can measure sweat gland function now to help diagnose people with autonomic neuropathy, and there's some indication that can be helpful. But yeah, these are all things that can improve after decompressing those nerves. And Scott Nickerson is a colleague of mine who's an orthopedic surgeon who's retired, and he helped publish a paper from a large subset of data showing that if you have these nerves decompressed, the tibial nerve, the common fibular nerve, the deep fibular and superficial fibular nerve, that you can reduce the recurrence rate of ulceration from about 20 to 25% down to 3 or 5.
Wow.
So, huge benefit. And we've seen this in patients who had one side operated on and then maybe some delay for whatever reason to get the other side done, and they ended up ulcerating on the side again that hadn't had the nerves decompressed. And Shai Rosen is a plastic surgeon down at UT Southwestern who is involved with a massive randomized controlled study looking at whether or not these surgeries are as effective as we think they are. And they are looking at it from every angle you possibly can imagine. They are involving the endocrinologists, the primary care doctors, the surgeons doing the surgery, and trying to establish baselines for who would benefit from this type of surgery. And I think the preliminary results were really outstanding, showing that you could reduce ulceration rates, you can reduce complications when you do these nerve decompression surgeries. So the long-term, I think, data is still out there. They're still, calling that. They've only released a small amount of preliminary data in the last couple of years. That was presented at the American Diabetes Association meeting. I think that was in San Diego a couple of years ago. But we're waiting to hear how this huge study finalizes. But all the preliminary data was really positive, so it's exciting.
Yeah, all we're doing is we're trying to get more sensation back to the foot. So as you go down this tract of lack of sensation, lack of muscle function, and deformity, you end up getting that repetitive trauma. Patients end up coming with calluses. They end up getting in the bruising under the callus, and you get that little subcutaneous hemorrhage. And you're like, oh, I'm just going to debride that way. I have a suspicion that there's something under there, because you can kind of feel it. It's fluctuant. Sometimes it can be red hot inflamed if it becomes infected. You debride it away. Wow, there's a ulcer under there.
And the patient sometimes says, well, did you just create that wound? I'm like, no, wait a minute. This is the tip of the iceberg effect. You're seeing tissue loss underneath a callus that was there before we debrided it. All we've done is exposed it, and for good reason, because that's the only way you're going to be able to get this thing closed, is you've got to get rid of all that dead tissue. You got to get rid of all that overhanging tissue and allow the wound to fill in from deep to superficial.
Yeah. So I typically try to debride away half of it, and I show them, look, it's tenting. Let me show it to you. This is what's going on, because I don't want patients to think I'm doing harm to them. I want them to see that this has been going on. Right. That callus is like hard as a rock. It's like they're walking on stone.
Calluses in diabetic neuropathic patients should be a red flag. And so I think there's this weird thought that calluses protect you. I mean, weightlifters get them on their hands, and people think it's construction workers get them on their hands. They think they're protected. They're really not. And when they're on your foot and you're neuropathic and you can't feel pain, they are a huge red flag. They don't pop up out of nowhere. They are occurring because of friction and pressure at that site. So you have to offload that site somehow. And sometimes that requires surgical offloading. And sometimes, we can do that with diabetic shoes and other padding, but that should be a red flag. So if you're a diabetic and you have neuropathy and you have calluses, they're not a benign problem. They are a red flag telling you that there's a pressure and friction problem at that site.
And plus, insurance covers all this.
Yeah.
They cover for your callus and things. Debris. When you have diabetic with neuropathy, they don't cover them otherwise. So there's a reason behind it. Insurance is not going to pay for anything that isn't going to be medically necessary. It's a very simple logic. They've done their research. It's been proven multiple times, and finally able to convince insurances, taking the pressure off of these areas, debriding them down, is going to prevent them from getting ulcers, getting infection, getting bone infection, and getting some type of amputation, which is far more expensive to them in the long run.
Absolutely.
So here's a little progression of foot ulcers. You can see it's a pressure area on the grade 0, and as it progresses, it gets deeper and deeper and deeper. Level 3, they're talking about down to level of bone, and that's our biggest fear. Once we get down to level of bone, we're talking about bone infection. Bone infection in adults is incurable. It can be subdued, but it can't be cured.
It can be, but it involves an amputation usually. So that's the downside. But I don't want to scare people to the extent that this is the progression that all wounds go through.
No, we try to stop it at grade 1 and
we're
reverse.
Intervening. Yes, absolutely. And then the grade 4 and grade 5, typically, that you can see gangrene in a massive infection, but usually that situation is based on vascular issues. And so the wound is clearly a problem, but if you don't address the blood flow, if you don't address the perfusion issues, then you're not going to get anywhere. So, that 4 and 5, thankfully, are not extremely common, but they do happen, and they are an emergency, absolutely. But so is grade 2. Grade 2 is an emergency, and that's really what I think patients need to understand.
There's different levels of classification systems that people use. Wagner, UT. This is the Wi-Fi classification. Dr. Armstrong actually met him. Very, very smart guy. But in general, they're all fairly the same. They're all measuring the level of infection, level of
depth
tissue
of the
loss,
wound, right.
and then the vascular component to it. So, what are our treatment options? What we typically do, and it's a combination thereof of wound debridement, infection control, vascular optimization, offloading, be it your shoes, insoles, total contact cast, a boot, exactly. Hyperbarics when available, wound vac, and then some type of skin graft or biologics, and we'll go through these very simply. So wound.
It's just a flesh wound. It is not just a flesh wound, Dr. Hussain.
So
way more important to that. That's great. I love that movie.
So wound debridement, what we're doing is we're removing all the devitalized tissue, all the dead tissue. It's like if you have a lawn and you have nothing but weeds there, regular grass is going to have a difficult time growing there. What we're doing is removing all the unhealthy components to the wound, getting down to a healthy, bleeding, granular base. That's your beefy red base, and hopefully getting it so it can grow in naturally.
I liken it to like you're trying to get a garden to grow. You got to prune it back. So we're pruning back all of the dead, devitalized tissue, and we're trying to expose that beefy red granulation tissue and encourage that to grow. And you're going to need to probably do some pruning weekly for a while until you get that red beefy granulation tissue to fill the wound, and then skin's going to grow over it. But these are great. So these are well debrided wounds. So if you're before and after pictures with whoever's treating your wound, if you have a diabetic foot ulcer out there, if the before and after pictures don't mimic these, then whoever's treating you may not be doing an aggressive enough debridement. And you need to understand why that is. Is it because they're worried about your blood flow? Are they addressing your blood flow? Or is it they're just not comfortable with debridement? And I think that's one of the problems. Yeah. There's still a lot of diabetic foot ulcer care that's being done in the clinics and not in a wound center. And there's not a lot of oversight there. And if the answer is they debrided my wound every week for 2 years, that's a problem. You have to be more aggressive with these. You can't just debride them every week and then hope that they'll heal. If these wounds aren't closing by 50% within a 4-week period, they only have about a 3 to 5% chance of healing within 12 weeks.
Yeah.
If they're closing by 53%, then they have about a 67, 70% chance of closing at week 12. That's a big difference. Very few things in medicine are black and white like this. It's a lot of gray area. But in this case, we know if that wound's not closing by 50% within 4 weeks, it's got almost no chance of doing it by week 12 if you don't intervene. So intervention would mean, offloading, throwing everything but the kitchen sink at this. We can get them into the hyperbaric chamber. That would be fantastic. Sometimes we'll use growth factors. Sometimes we'll use amniotic tissues, anything to push it in the direction of wound healing.
Yeah, because we're fighting an uphill battle when we have a wound. It's not something that, we'll just fix this one thing. We'll make you switch your shoes. We'll put some antibiotic ointment on there and it's going to get better. No, we're fighting a multitude of problems that have kind of added up and got you to this point.
Right. And vascular testing is extremely important. So that, number one, we're going to debride the wound. We're going to check vascular status either with a blood pressure cuff system or sending them to get arterial Dopplers or doing TCOM. So transcutaneous oximetry is something we do in the hyperbaric world. It's an electrode that reads oxygen coming out of the skin, and it can tell us if that wound is getting enough perfusion to heal spontaneously, or does it need some help? And then we'd send you to a vascular or interventional radiologist or cardiologist. Yep.
And before we get too far deep into the wound, we're typically taking cultures. Mm-hmm. Very commonly, these wounds come in when some type of baseline infection, be it some type of staph, superficial like staph epidermidis or staph aureus, hopefully not any type of MRSA type infection, but we're getting cultures. We're making sure that the topical agents that we're using on this are going to be able to maintain the infection control. If it's a difficult infection, we'll get infectious disease involved. We'll get you on some type of oral antibiotic or IV antibiotic, depending on how deep the infection is.
And then most of these are polymicrobial. So in other words, there may be 4 or 5 different bacteria involved. And when it gets that complicated, and maybe the patient's a dialysis patient and they've got multiple medical problems, they're on multiple medicines, that's really where, I like to punt to the infectious disease guys and have them help us make that decision. Yeah, because they're going to be able to manage the kidney function aspect of it to determine whether or not there needs to be adjustments to the medication and all that. Those guys are so good at that.
So some things that you're looking for wound infections. Mm-hmm. So I only bring this up is because a lot of our neuropathic patients don't feel the pain associated with it.
But they can't use pain as an indicator. Absolutely.
But if you see red, hot, swelling, any type of pussy drainage, something like, that's not clear white or lightly yellow and tinged, you're looking at some type of infection. Call your doctor. This is something that you don't want to base off of pain. If you have, I can't tell you how many times it's happened where patients are like, you know what, I was scheduled for an appointment in like a month or so I thought I'd just wait until then.
It even drives me nuts when they say, well, I had an appointment on Tuesday and I noticed this on Friday. I'm like, where were you?
Yeah.
We're on call 365, 7 days a week. One of us is here. So yeah, don't let that kind of thought process lull you into believing that you're going to be okay when 72 hours from now you could end up with a major amputation.
Yeah.
So it happens. I've seen it too many times to count. So
vascular optimization, that's very, very important. And most of these patients that we see, we need to get good blood flow down to the extremity to get that wound to heal. Mm-hmm. They estimate that 1 in 20 Americans over the age of 50 has peripheral arterial disease. And a lot of the patients that we see with diabetic foot ulcers are over the age of 50. And very simple thing. That's when we get our specialists involved. We do our vascular testing. We do our ABIs. We do our pad nets. We see how much blood flow is coming down. And if need be, the vascular doctor will intervene, be it, some type of angioplasty. That's your rotor-rooter type going in and cleaning up the vessels. They can put stents in to open up the vessels. Or if they need anything more, they can do any type of bypass. I mean, one of these days, we'll have the vascular doctor come through, and I think we can pick his brain.
So 8 to 12 million people with peripheral arterial disease in the United States. That's just a huge number. And a lot of this is being driven by, I think, smoking history. A lot of it is being driven by clearly diabetes.
Uncontrolled diet.
Yeah.
I mean, all your high lipid type diets. I mean, you're going to get plaques, and it's a known risk factor for any type of lower limb amputation.
And our interventional guys would look at that stat. I'm sure they pushed this stat. The 65% of patients undergoing limb amputation in the U.S. did not have an ABI document. Or and it's not just an ABI. They're saying that is the baseline,
Yeah.
but didn't really have any vascular testing done before the amputation, which is frightening. That's really scary because from an interventional standpoint, how many of those limbs could you have saved?
Yeah, there's so much we can do as part of treatment for lower limb amputations to prevent that from happening. The baseline, what we're doing is the wound care, the infection care, but there's a vascular component to most of these problems. If we can get more blood flow, more nutrients to the wound site, that's just going to heal up that much faster.
Well, and it's how you deliver antibiotics.
Yeah.
I mean, you've got to be able to get antibiotics to the area. So that's this is really great stuff. So this vascular intervention slide you got here, I think really shows kind of what we used to do. Or I say we would refer patients to vascular surgeons. I think the open bypass, where you can see in the upper right hand corner where they would graft around the blockage, was the going procedure. And now things have evolved, and now they're doing way more endovascular work where they're using stents. And this is a great picture of those stents in the middle. So it's a cage. They're using a balloon to open up that cage and press the plaque up against the walls just to recanalize the lesion. So they're opening up the blood vessel and then having the cage help keep it open. Yeah,
what happened was, before, when they used to do angioplasties, there was a limitation on how
long it would last,
and how low they can go. How low can you go? As how close to your toes you can get to. They used to really get to the trifurcation where you're
behind the knee.
Yeah, we're behind the knee, and that's pretty much maybe a couple centimeters further. But besides that, there was a real limitation. Now there's people that are actually doing it retrograde. That if they can't get past the behind the knee portion of your popliteal artery, they can come up from your ankle and open it up that way. I mean, it's so much more advanced than it used to be.
Right.
So I think we're seeing a lot less bypasses and a lot more angioplasties on a whole. I mean, what do you think?
Oh, absolutely. No, definitely. I mean, if you talk to the vascular guys now, it's probably 80-20. I mean, we ought to have one on and get the latest stats, but I'm sure they're doing, 1 in 5 open, and it's a good thing because those incisions are huge. You can have wound healing complications from those large incisions running all the way down the leg, and now if they can do it endovascularly, it's a small incision that heals up beautifully in the groin, and that's it. Yeah,
it's a day in, day out procedure. You have a 1 centimeter tiny little stitch.
Right. Smoking raises the risk of PAD by 400%.
Yeah.
That, I mean, if we can get, I've convinced. I used to keep track of this because it was like a badge of honor, like how many people I got to stop smoking, and it's in the hundreds and hundreds. It's probably up to like 500 now over 21 years. But that's really one of my bugaboos, and it's really hard to rationalize spending tens of thousands of dollars on wound healing technology, amniotic tissues and growth factors and surgeries when someone's not going to stop smoking.
Just doctor's office visits, that costs them money too.
Yeah. And so, it's almost like, are you going to do a liver transplant on an alcoholic who hasn't stopped or who isn't willing to stop? That's a tough question. It's an ethical question. It's difficult. So I have some patients that, are clearly still smoking, and they're honest with me, and they still have wounds, and we're doing everything we can to get them closed, but we're struggling. It's really hard. And we're using the latest and greatest technology because they're the folks who need it, but they're their biggest enemy. They're making it so much harder.
Yeah.
And it's an addictive drug. I get it. Nicotine's an addictive drug.
So offloading, very simple, very effective. All we're doing is pretty much taking the pressure off of the ulcer spot, just like we showed in that first picture where the sore was under the second metatarsal head. If we take the pressure off using our insoles, using our boots, using our total contact casts, whatever it might be, simple thing, very effective. Standard of care.
I like that the suspension boot that you have there.
Oh, the 0G.
Yeah, I think that's cool. I just they're the folks that I want to use it on. I think are so frail that you don't want to get them a hip fracture over a problem.
Yeah, you're better off putting them in like a wheelchair or something.
But I do like that for the younger. I think a little bit more a physically adept patient who you're not going to cause them to take a tumble, because that is a really cool thing. So it's essentially, putting all the pressure on the calf and floating the foot entirely.
Hyperbarics. So this is, I don't know, it's easy, slam dunk as far as treatment goes. Hyperbarics is you're putting 100% saturation in a chamber, in a room, or whatever it might be, of oxygen. Now,
so this is oxygen under pressure.
Yeah.
So you're at 2.4 atmospheres. I've been doing hyperbaric medicine for 20 years, and it is one of the most effective ways that we can turn wounds around. You can super oxygenate all of the tissues around the wound, and that causes the oxygen gradient to be thrown to such a degree that the body says, oh, that is a dead space. That wound is a dead space. And it starts to grow new blood vessels to feed that tissue. And it is tremendous at decreasing edema. And so when you decrease swelling, get rid of all that tissue fluid around the wound bed that's just diluting nutrients, and you super oxygenate the tissue around the wound, you can really jumpstart the wound healing process in a wound that was essentially being ignored. So you're converting, by debriding it and you're getting the patient into the chamber, you're converting a chronic wound into an acute wound pretty quickly. And, oxygen is vital for our white blood cell killing process. And so for it to be able to be antibacterial, you have to have oxygen. So you get a double whammy there.
Yeah, this is very simple. I mean, you literally go in, it's not invasive. You sit in a chamber, you're watching TV, and it's saturating the air around you. I mean, to the point where
you're basically at 60 feet of seawater. So it's the same pressure you'd feel if you were scuba diving at 60 feet of seawater.
Most commonly, the patients will notice that even their eyesight is slowly getting a little bit better.
Yeah, that's a temporary benefit. But yeah, we tell patients don't make any changes in your prescriptions while you're having treatments, because when you stop, it'll probably revert back. But yeah, they do find that is an interesting side effect.
Well, this is exactly what Dr. D was talking about. The oxygen under pressure promotes more nutrients to encourage blood flow and growth. Very simple, very effective. Wound vacs. So I'm a big proponent of wound vacs. Very simple treatment as far as logically speaking. When you explain it to a patient, you're putting negative pressure on a wound, you're taking all the excess fluid out, and we're promoting vascular growth into the wound. It's like a tiny little vacuum that you slap onto the ankle that's pulling nutrients to the wound bed. And then you can use your grafts, you can use all your stem cell therapies under that, and hopefully force it to heal.
I used to joke that if you took away negative pressure wound therapy, hyperbaric medicine, and skin substitutes away from me that we've had access to for the last 20 years, I would struggle getting wounds to close.
Yeah,
because we are so dependent on those three modalities in 2020 because they work so well, and they work in combination with each other. They work synergistically. So, I think you can really stabilize and address very large, deep, cavernous wounds with negative pressure wound therapy. And, doing it before, I was part of, the generation of wound care docs that didn't have access to this. And I remember when I was at Scholl in Chicago working with Jack Leese, who was a plastic surgeon at a wound care center in Chicago. Really nice guy, taught me a bunch. We were basically coating Curlex rolls, which are cotton rolls, with Silvadene and packing these massive wounds in the hip and in the buttocks area and in the abdomen. And they were using that as sort of a, not really a wet to dry, but essentially as a packing mechanism.
Iodoform packing.
Yeah, and you didn't have access to something like that. Now, clearly, all of those wounds are being addressed with negative pressure therapy, with these units that are accomplishing so much more than what we were able to accomplish by just packing the wounds with Silvadene impregnated gauze. But that was the state of the art in 1995. So, that was all you had.
Medicine is advancing. There's a lot more than just doing any type of antibiotic ointment and a gauze type dressing.
Right. And then that's the other thing we got to touch on. Moist wound healing is the goal. And we still have this strange thought process that you need to let wounds air out. And that was probably the case in the Middle Ages when we didn't have wound gels and negative pressure wound therapy and all these fancy things we have now. But it's amazing that thought process permeates not just Americans, but I have people from Europe and Asia and South America and Australia who all say the same thing. And I'm like, no, actually, that's not what you want to do. You want to keep the wound moist. You want to obviously control infection, but if infection's under control, you don't want to let a wound like this dry out. It's just going to scab over and take longer to heal. Yeah. So yeah, I mean, this is a great negative pressure series of diagrams you have here, and really beautiful wound examples with exposed tendon.
Yeah, those are your tendons on the top of your foot that you can see in that picture. They did the wound vac therapy. They watched it heal over. You want that granular tissue to come back over those tendons, and then once you get to the point where all the tendons are covered, I typically will put some type of skin graft on there or some type of stem cell therapy, and hopefully complete it all the way. Just push it to that finish line.
And with the top of the foot, you can use a split thickness skin graft, and that was done here, and that makes sense. But on the bottom of the foot, that doesn't work very well. The tissue's not durable enough, and so that's where we'll go with more of the amniotic tissues to really let the body fill that gap, and instead of trying to split thickness skin graft, because you end up with this corrugated cardboard appearance to the tissue. It can be more scarred and less durable to weight bearing pressure.
Yeah, more likely to fail in the future.
Right. So we try to avoid that on the bottom of the foot, but yeah, clearly split thickness skin grafts work great. This is these are awesome.
Yeah, so just like Dr. D said, you get that corrugated effect. That corrugated effect is from we fenestrate or mesh or whatever you want to call it, the graft, so it can cover a larger area. So if we're taking it from their thigh or their calf or their abdomen, we can cover a larger surface area. So we're not trying to cover it from cover one wound by causing another wound. Mm-hmm. And typically when I do this, I'll cover the graft site with the stem cell graft. And hopefully heal up both wounds fairly quickly. And I do use the wound vac on top of these. It works very well. It prevents, any of your seromas or hematomas from forming under it.
Right. You don't want fluid underneath your graft, right?
Last thing, amniotic stem cell therapy. Very, very new age? I don't know. What do you want to call it? It's probably
Well, I think amniotic tissues, placental tissues, have been around for 100 years.
Yeah, the problem was like the 1890s when they first started using them, something like that.
They were slapping them on stuff at Johns Hopkins in the early 1900s. The problem was they realized pretty quickly that they didn't have a way of processing this tissue, and so that really made it fall out of favor until the processing technology was developed where they could make these tissues safe. To just be able to screen patients that were donating these tissues and then also be able to test them. So once that hurdle had been eliminated, now we have access to a ton of umbilical cord materials and amniotic and chorionic materials from the placenta and the umbilical cord that can do some pretty amazing things. And there's some really good level 1 studies. This one by Teitlbach, I read that one that you have here using epifix is, the mimetics folks have done a good job of putting out some really well done research to prove what epifix can accomplish. And I think we use it frequently because we can just pull it off the shelf and apply it to an appropriately prepared wound bed and really see some terrific improvement in the wounds week by week.
Yeah, in this study, at the 12-week mark was where they're trying to measure their primary outcome. Mm-hmm. 81% of wounds that were treated with the epifix versus 55 with baseline therapy. 81%. I mean, that's the group I want to be in. That's the group I want to be treating.
And they were, I think, the 55% standard of care. The standard of care was essentially moist wound healing.
Yeah, antibiotic dressings, zero form adaptic, iodine.
Yeah, nothing too fancy, but very common. I mean, that's the standard. And you can see when you're essentially limited to the standard of care, you're not going to get that wound closed in a reasonable amount of time. So Caparuso, that's Joseph Caparuso from one of our colleagues down in South Texas. So yeah, a little shout out to Joe.
I got a couple other ones in here. I mean, this was a randomized control trial for epifix versus standard of care dressings. You can see at the 1 week mark to the 6 week mark, where it's just far faster. There's growth factors that we're missing. There's something lacking that's not allowing these wounds to heal. So when we use any type of stem cell or any type of skin graft type substitutes, we're putting back what's missing to force these wounds to the finish line, to get them to heal up completely.
Part of it's scaffolding. So part of it, you need to have a scaffolding matrix that the skin cells can grow over. And then, like you said, the other part of it is really growth factors. The diabetic patients are deficient in growth factors, and so these wounds stay chronic, and the body's not addressing them. So we turn them around by debriding them, getting rid of the dead tissue, getting some acute bleeding, and then applying, a matrix, a scaffold that has some sort of biochemical response in the wound bed. And placental tissues have been shown to be really effective for that.
So some last facts, some last stats for you guys. Like we already said, 15% of people with diabetes will develop a diabetic foot ulcer in their lifetime. The hard stat right here, every hour, 10 Americans undergo an amputation due to diabetes, and 50% of all diabetic foot ulcers will become infected, resulting in hospitalization, which is another cost,
Right, and another very preventative problem.
Yeah, and then last, up to 24% of all diabetic foot wounds will result in an amputation. 24%.
And it doesn't have to be that way.
No. Yep. Well, thank you for listening to the podcast. Thank you for tuning in. Please like, follow, subscribe, thumbs up, whatever you need to do. And trust us, we're the doctors.
We'll see you next time on the PODdoctors.